This session, we sort of, a lot of people, as we did our background preparatory work, a lot of the interviews we had with people, one of the questions that came up this morning as well, is what were the precise plans from the CDC? Where was the CDC heading? What were some of the issues with regard to the insurers, as we've heard as well this morning? So we wanted to sort of save this so that people wouldn't leave our meeting, so that they would have an opportunity to hear from Gilead, from some of the insurance companies, and from the CDC as to what their guidance plans are, or their intentions at this point. So on this panel, we have Dawn Smith from the Centers for Disease Control and Prevention, who's the Biomedical Intervention Implementation Officer for the National Center for HIV/AIDS Prevention. We also have Michael Allerton, who's the HIV Operations Policy Leader for Kaiser Permanente Northern California, who we've heard from occasionally during the day as well. We have Ed Pizzala, who's Aetna's National Medical Director for Pharmacy Policy and Strategy, responsible for Aetna's public policy positions on pharmaceutical affairs. And finally, we have Jim Rooney, who's Vice President of Medical Affairs for Gilead Sciences and Industry Co-Chair of the Forum's Executive Committee, although I believe you're rotating off as the Industry Co-Chair. So you're almost the past Co-Chair. So, emeritus, right, yeah. So with that said, I believe we have some slides for Dawn Smith to use.
So obviously, in terms of generating guidance, we begin with collecting the relevant evidence, generating and collecting the relevant evidence. And I don't know if this is okay. And then step 2 is actually putting the evidence together in a way that we can synthesize it. Step 3 is developing the guidelines themselves and any associated policies. And then we get to actually try to use the guidelines. But I think the important part about this slide is that nothing that we do in guideline or policy development supplants the eventual clinical decisions that get made in the office between the provider and the patient. As we approached developing guidelines for PrEP, we were very lucky in that the whole institution at CDC was interested in thinking through its guidelines process. And so we've been working with other branches, with other parts of CDC as well, to think through how to do guidelines in a more effective manner. So we started by looking at the recent guidelines that seemed to be related to what we were doing, the NPEP guidelines, the STD guidelines, and the ARV treatment guidelines, not just looking at content and organization, but looking at what the procedures were in developing those guidelines. And then we've been involved in a review of the literature. There's an extensive literature about guidelines and what makes a good guideline. And there were 2 particular elements of that literature we focused on. One was different methods for assessing the strength of evidence as the basis for recommendations. And the other is factors that are associated with making guidelines usable. And so you can see that, some of those things are, there's a whole system for scoring guidelines on their implementability. There's a lot of work about dissemination of guidelines, which is more than just putting them up on a website somewhere. Being able to monitor the adoption of guidelines and the fidelity to guidelines in clinical practice is an indication of whether your guidelines were well written. So we started by thinking about, well, what do we mean by guidelines? And this is an adaptation of the IOM definition, that it's systematically developed, scientifically supported recommendations, strategies, and information that are intended to assist practitioners and seek to minimize harm in the delivery of health care. Guidelines should be explicit about the following things. Under what circumstances should the guidelines be used? Who should be implementing the guidelines? What ought people to do? And do what things to what people, in what manner, and for what reason? So thinking about evidence rating systems, these are three of the most popular ones. There are probably 10 or 12 different evidence rating systems. The CDC Guide for Preventive Services is one that has not widely been used at other places in CDC. And so CDC, like WHO, has recently decided to adopt the GRADE criteria for rating the evidence that supports guideline recommendations. And the general approach of all these systems is to take into account both the kind of data collection. Was it a randomized trial? Was it an observational study? Was it expert opinion? And the quality of the resulting results. So did they have some kind of biased enrollment criteria? Did they have significant losses to follow up that might bias the data? And there's a process by which you kind of make a basic assumption. So you start out with a randomized clinical trial, for example, saying this is excellent quality. But then you either give it extra points or take points away for some of these additional factors. And then you summarize all that into an evidence table that is apparent to everyone who's reading the guidelines, how you used evidence to support whatever recommendation you end up making. We're also considering whether for the PrEP guidelines, we want to use a grading system, the same grading system that's used for the ARV treatment guidelines. Since some of practitioners are familiar with that, we're not sure how we want to manage that. But you can see it's the same kind of a process where you have a part of the grade that reflects the quality of the evidence, and part of it is trying to indicate how much evidence you have and of what quality to make a recommendation. Now, the formal grading of the strength of evidence focuses on safety and efficacy. And there are many other things that people are concerned about that you heard here today. The efficacy of screening for a condition, adherence to medications, other procedures that you want to have in place, and also cost and cost effectiveness. It's useful to note that although health reform and other issues talk a lot about cost effectiveness, the current position of both the CDC Community Guide and the AHRQ U.S. Prevention Services Task Force is that cost effectiveness is not used as an element of grading the recommendation. It is a comment section that gets made. So given whatever the strength of your recommendation is, what are the cost effectiveness implications? One other thing that we're working on with the new draft of the guidelines is being very careful in our language. This is an example of a study that was done by a group where they surveyed a lot of clinicians using a variety of terms. You ought to do this, you may consider this, you should consider this in certain circumstances, you must do this. And they were basically able to show that when you want people to do something as a standard of care, you need to use language like must. When you want people to consider something as an option, but not feel obligated to do it, then you need to use language like consider. So we're trying to be careful in writing the guidelines to be very clear in our language what things we're making mandatory, essentially. So things like repeated HIV testing will be must statements, whereas specific means of counseling will be options that, you must provide some counseling, but you don't have to choose this method or that method or the other method. They also talk a lot about what they call unclear language. This is also called AVUL. So ambiguous, vague, and underspecified language should be avoided at all cost. And many of the guidelines that we all read have these problems. Now, they also point out that there are times when you specifically want to be vague, but that you have to be clear when you're doing it intentionally and when you're not. For the PrEP guidance, we're actually thinking of three kinds of guidance. One you've already seen, which is the brief guidance that came out for PrEP use in MSM. What we're talking about here today is the full PHS guidelines, which are really supposed to be clear and complete guidelines about how to go about using PrEP. And these have to be widely vetted. And then those, we hope, will be followed with particular programmatic guidelines. So if you're doing it in an STD clinic and you need to be thinking about how to integrate it with STD services, then you might have a short program guidance for that would look different than what you would do in a family planning clinic. So the strength of evidence determination for PrEP guidelines will be primarily based on the RCT findings, but it will also be informed by other evidence that we have from ARV prophylaxis for PrEP and perinatal, from pharmacology studies, and a great deal of information from expert opinion. This is basically our process. So people always ask, well, why does it take so much time to get CDC guidelines out? We're actually on the right side of the page now, which is a good thing. Over the last 2 years, what we did was we formed several working groups, both a working group that included PHS agencies like FDA, HRSA, CDC, VA, and then we formed a set of external working groups that include academicians, CBO representatives, scientists, to consider specific aspects of things that would go into the guidelines. So, for example, there was a clinical working group, there was a counseling working group, there was a working group around how to integrate PrEP with other prevention services. And then there were working groups that were about the specific needs of some subpopulations. So there was one for women and one for MSM and one for adolescents. And all of those working groups got a lot of input from both internal CDC PrEP-related scientists and from advocates and calls that we had with community representatives. So the idea was that when the trial results came in, we would have a lot of background information and we could proceed rapidly to write guidelines. We used that information to write the initial guidance, and we now have a draft of the guidelines that are starting into the clearance process. We have structured the guidelines in a way that resulted from conversations with WHO, in that they will be guidelines for PrEP use in the United States, not for PrEP use with MSM. And within the guideline structure, then, for each transmission risk group, there will be a section that talks about how much evidence there is for PrEP use in that population and what the recommendation is for that population. And we did that largely because as the new trials come in, we didn't want to be in a position to have to develop a whole new set of guidelines. So as you can see, there are a number of steps in our clearance process. So the initial thing is that they get cleared through the Division of HIV/AIDS Prevention. Then, because PrEP is such a high-profile situation, they will get cleared through the CDC leadership, including the policy team and the science team at the Office of the Director. Then they will go to HHS for clearance, and at the same time, they will go for cross-clearance with other involved agencies. So FDA, for example, will be looking at them and be making comments to be sure that they meet their concerns. NIAID will look at them, HRSA will look at them. There are a few federal agencies that will have to cross-clear them. Then they will go to a panel of external peer reviewers who we have already selected and who have agreed to do that. and at the same time they'll be posted online for public comment. I don't remember, Robert, is it 30 days or 60 days? Do you remember how long those stay up? Oh, so somewhere between 30 and 60 days. And then all those comments get collated, read, organized, and whatever changes are indicated, and then we can publish the guidelines. So we're hoping that we could be able to get that done by early next year. We also considered how long the guidelines should be, and there's a lot of evidence that you can write the definitive statement that has, 69 pages of text and another 100 pages of appendices, and they're not very usable. They're very satisfying to the scientists, but they're not very usable to the clinicians. So we're trying to opt for a more modest size for the document and then provide some of the more detailed things in supplementary documents that would go up at the same time. We hope to publish them primarily by posting to guidelines websites, and this will allow us to promptly update them as science develops. This is the same procedure that's used for the ARV treatment guidelines, and gets around the issue of having to have these long clearance paths every time you want to make an update. So if you have more questions, that's how you can contact me. The IOM has recently published in the last month a result of their deliberations about what makes good guidelines and good guidelines development process. And so if you have more questions about that, I would direct you to their site where they have slides from all the meetings and all the presentations as well as the full report. Done?
All right, thank you, Dawn. For those people who are attentive to the agenda, we do have a typo, and so we're going to have a little less time for audience participation than I had hoped. That said, this session is really much more about external organization plans and not so much the safety topic that we wanted to address. So I think we'll be okay. Let me turn it now to Michael Allerton from Kaiser Permanente, and I believe you have some slides as well. There you go.
Thank you. I appreciate the opportunity to be here. My job has been made much easier today because so many of the things that I was concerned about and wanted to stress have already been very, very well said and spoken to already. But my job has also become a little bit harder because I've heard a lot of misconceptions and ideas of just exactly what Kaiser Permanente is. So I have to start out with who we are and what we did before I can really tell you what we plan to do. So I was prepared for that. It's times like these that I really think it's important that I make some distinctions between what we are as an organization and what a large integrated system is able to do versus a standalone or even a standalone provider or even a clinic of providers, because there are some very important distinct differences. This is sort of the Kaiser Permanente mission statement that would be attached to any press release that we send out. It describes who we are. And there are a couple of really important pieces to this. And one of those is that we are leading healthcare provider and not-for-profit health plan. That's two separate and distinct things. The provider side of our organization is the Permanente Medical Group, of which I am a part of. I'm a part of the Permanente Medical Group. And there is the health plan hospital, which is actually the insurance side of the organization, and they're distinct and separate. So there's been a little bit of false advertising. I'm not representing insurance part of Kaiser, although I do want to speak to that aspect because although it's schizophrenic, we really are one organ. Externally, we are Kaiser Permanente. Internally, there's that distinction. We provide care for 8.1 or 8.8 million members in 9 different states and the District of Columbia. So it's a significant population that I think we can talk about and base our experiences on. And when it comes to this topic, the personal physician, specialist, and team of caregivers is really the important piece, because our model of HIV care since 1996 has definitely been one of multidisciplinary care teams and use of a variety of healthcare roles in responding to our patients and to our members' needs around HIV. We really do have controlled distribution strategies that do not impinge on physicians' free and autonomous ability to prescribe. We're very proud of the fact that we don't have a 1-800-MAI-PLEASE number for clinicians. But that doesn't mean that we don't have restrictions in place for initiation of HART by the appropriate people, and that we have models that we have used for PEP that have really been strong communication plans between our HIV clinics, our primary care providers, and our emergency department, so that PEP is appropriately provided and maximized. So the structures are there, and I think that some of the things about PrEP that have come out have really built on the foundation of our structures. A little bit on just the numbers. I'm going to have to turn the page here because I can't read that slide. As you can see here, we have 60,521 patients individually cared for since the beginning of the epidemic. In Northern California, we have over 6,600 HIV-positive patients with a 20,000 plus almost 21,000 patients cared for since the beginning of the epidemic. And that has allowed for us to have some very interesting data. We have an integrated medical record, and we have an integrated HIV registry nationally. So the reason I have all the national numbers up here, even though I come from Northern California, is because our outcomes measures and our data on quality are both drilled down to the provider level, so each physician will know what their quality outcomes look like for their HIV patients, and then gone all the way up to national. And the piece that I wanted to stress, and the reason for putting up the demographics and statistics, is that we know that our quality outcomes, you'll have to trust me, they're very good, but I don't have time to tell you what they all are, but we know that our quality outcomes do not vary by age, race, ethnicity, or geographic location. So what that means for us is that if you're an HIV-positive black female in the Mid-Atlantic region, your chance of a quality outcome is exactly the same as a white gay male in San Francisco. We can't say that about other diseases like diabetes or hypertension, and I don't think very many other delivery systems can say that about HIV and AIDS. But because of that, and because disparity is an issue, I want you to know that fact for when I talk about disparity issues in PrEP. So our initial concerns around PrEP and rolling out PrEP operation and policy was not about the data and the research as much as it was about member and community perceptions. When IPREX was announced to be released, you may remember back, that was late November of last year. There was quite a ability of lead up to the release of information. And in fact, with apologies to Robert over there, we were quite concerned about this promotion that was going out in the community. And it was basically, can a pill a day prevent HIV? Come find out. And it was promoted to the lesbian, gay, bisexual, transgender community, and in fact was held at their center for the rollout of the clinical findings. Now, as Mitchell said, and as you all well know, we know that this is not a pill a day, and we want very hard for people to know that this is not a pill a day, and anybody who was aware of the research knew that the results were not going to be about a pill a day, but we were quite concerned that the community demand would be about a pill a day. And we had some experience of that. In San Francisco, there were some anecdotal stories of some well-known key HIV providers who are already prescribing this. Michelle Rowland, who is the medical director of the State Office of AIDS, at one point prior to this date, had already conducted a survey of providers to see if there was, in fact, some PrEP prescribing and some PrEP utilization going on. And we had sporadic requests from members prior to any data. So once data came out, we were concerned what the demand from members would be. Ironically, IPREX, as you know, was MSMs at high risk, but one of the highest rates of demand for pre-exposure prophylaxis prior to that was from our HIV-negative women in discordant couples who were trying to get pregnant. In the state of California, we've had some very difficult issues around sperm donation and sperm washing and IUF being provided to HIV-negative women with positive donors, and their only option is to have unprotected intercourse or timed intercourse, and they wanted pre-exposure prophylaxis, and yet we knew the data was going to be limited to MSMs, at least at this standpoint. So we were really concerned about the community demand. And one of our lead HIV pharmacists attended that meeting, not to hear what the data was, because by 10 o'clock on November 23rd, we already knew what it said because it was released at 4 a.m. our time, or 6 a.m. our time. And so we'd already had the clinical results. We wanted to know what the community questions were going to be like and what the community demand was going to be. So what was our response? That was on Tuesday, and that was the Tuesday before Thanksgiving. So we convened our HIV steering committee, which is one clinical practitioner, one physician in HIV care at each medical center, and one care coordinator at each medical center, to find out what our response would be. We conference called with HIVI, the National HIV Management Committee, which is chaired by Michael Horberg, who was here this morning. And we developed frequently asked questions and an interim guideline for primary care practitioners, and we did that all by Monday morning on the 29th. We drafted a 2-page letter to local HIV champions to distribute. Now, what that meant was we had this draft text of what an interim guideline would be for clinicians, and we didn't want to send it out either from the National Program Office, because that would be definitely ignored. We didn't want to send it out from me or anybody on a regional level, because that would probably be read last of the day. So we distributed it to the champion, identified HIV champion at each medical center, so it would be a local provider sending it to their local peers, and we thought that had a much better chance of being read. Plus, this was a draft, so they could tailor it to their particular medical center and their medical center operations. One of the things that is in this letter and this draft guideline is this paragraph, which I just want to highlight a couple of comments from. And that is that basically this strategy and the idea of IPREX and pre-exposure prophylaxis fit very closely into something we were already doing with our clinicians in our education, which we had called Prevention 2.0. And Prevention 2.0 had been a year-long physician education program that stressed new prevention strategies should be thought of in the same way that we think of antiretroviral therapy. And that is, just as monotherapy doesn't work in antiretroviral therapy, a single strategy for prevention doesn't work. And I was really glad to hear somebody today mention smoking cessation, because we have used smoking cessation as a model for HIV prevention for many years, and that we want providers to identify risk individuals, and that can be something as simple as anybody with an STD. And lately I'm thinking anybody over 12 who's had sex. The button should be pushed, and then the auxiliary supplemental care team members should be brought in for working with them. We wanted to make sure that it was stressed that this was limited at this point to high-risk MSMs. And it also discussed, later in the letter, it discussed issues that were brought up in in that steering committee meeting and in the regional national HIVI meeting, and that was disinhibition was a huge concern of all of the providers on the conference calls. And the answer to that was it was hard to argue disinhibition for someone who had had syphilis twice that year already, and that we were focusing on the high-risk individuals who disinhibition was not going to be a concern for. We also, because of that year-long strategy of Prevention 2.0, really use this as an opportunity to stress that if you have a client who's coming in wanting to know what the pill a day is, maybe it's not the pill a day, but maybe it's the opportunity to talk to them about what we already know works in prevention. And maybe now's the time, because it's a teachable moment, to talk about what is the most effective proven strategies to prevent infection, and talk about things like routine testing and substance abuse. And, we even had one anecdotal provider who said, I've had people come in and asking for PrEP who haven't even had an HIV test yet. But that's what we thought would be the opportunity. And then finally, the last paragraph in this letter says that this is a dynamic and evolving, and the guidance would change with an unabashed plug for our soon-to-be-published National Prevention Guidelines, which were released in April. So additionally, we looked at IPREX as offering the great opportunity to stress HIV testing to our membership, provide outreach and education to primary care providers that was consistent with our Prevention 2.0 plan, and to reinforce the current successful prevention practices. So now to what I was actually brought here to talk about. Next steps. Well, Since then, of course, the interim guidelines have come out to replace our interim guidelines, and these really built on and expanded what we had already started with. There wasn't any need to change what this information had said. Then these were our these were our prevention and treatment guidelines that were released in April, and somebody mentioned earlier the ask, screen, intervene, and before you say, but we've proven that ask doesn't work, that risk assessment isn't work. Well, the ask here is just ask if they've had sex since the age of 12 and test. So it's a very low screening and really going into to what you should screen for with all adults or all individuals over 12, what you should screen for and what you should do for the wide range of what's happening. So in context, what we really want to do is continue to stress testing as an opportunity, provide that outreach, and we're going to be monitoring and looking for the demands for and the use of PrEP. But I started by saying that we implemented this based on the foundation that included our existing HIV clinics with the intensive multidisciplinary support components that are in our clinics, our experience with adherence, because we have a strong experience in monitoring capabilities because our pharmacy and our providers and our health records are all one in the same database. Context with the integration of the electronic medical records in pharmacy, and we have experiences with Nicorette and requiring educational components for the prescription of Nicorette and Accutane all in place. I did mention that disinhibition has been a concern that we have also constantly talked about, but again, one of our providers said that the issue for them where pre-exposure prophylaxis was an extremely important tool was they were talking about that patient that they have coming in, that it's not a matter of if they get infected, it's a matter of when they're going to become infected, and maybe now there's something to offer them. Now, the biggest issue for us, of course, is disparity. And I already mentioned that we don't have disparity in our HIV outcomes in treatment. But there will be a huge potential for disparity in those who can access this. And that's the part that I really see being misunderstood. People continually ask us, is Kaiser Permanente going to pay for this? Or is Kaiser Permanente going to cover this? And that is the wrong question. The question is, are Permanente physicians going to be able to prescribe for this? And the answer is absolutely yes. The question is, are patients who then get prescribed this going to be able to access that? And that answer is, it depends. We do not make the decisions of what the drug coverage employers and purchasing groups are going to make for our members. You may have a drug plan that, like mine, as a Kaiser employee or as a Permanente employee, has the premium plan. My copay for any drug that any physician deems necessary for me is $5. If you work for another company that has decided to carve out reproductive services, Catholic charities and Catholic hospitals have employees and they have Kaiser Permanente and they've carved out all kinds of preventive health services around reproduction services. Some purchasers, some employer groups have generic only. So if you have a generic only drug coverage determined by your employer, then your provider can still order this. You can still qualify for it. You can still benefit for it, but it's going to be out of your pocket. So the disparity issue for us is really an important and crucial one because we do not make those decisions and we don't want to lose ground on the areas in which we have maintained and prevented disparity. So that's where we are and what we plan to do. Thank you.
Thank you. So let me turn to Ed, and I believe you don't have slides, so we'll enjoy hearing from you.
Thank you very much, and thank you all for inviting us and for being here today. Aetna is a commercial insurer. We have 18 million members in the United States and a number of global operations as well. Today what I'd like to talk about is generally how managed care companies make decisions about coverage policies and then some of the systems around the enforcement of those policies. And the basis for all of this is that our basic business is to pay the bills. So a claim comes in and we have to decide to pay that claim or not pay that claim. So in the pharmacy business, it does get sort of tricky, and so I'll try to walk through it without spending an inordinate amount of time on it. As Michael said, the benefit design depends on whether or not you purchased an insurance plan and which plan you purchased, or you're with a self-insured employer who makes benefit decisions for you. And so you can have two people, we could have several people in this room with Aetna plans, and you could have an Aetna card, and your pharmacy plan may look somewhat different from one person to another. But generally speaking, our policies are established based on the medical evidence. So coverage for a prescription medication is based on the medication being approved by the FDA. If the drug is approved for distribution in the United States, then generally it's covered under your pharmacy benefit, and this is true of almost all managed care companies in the United States. Now, there are some plans that have what are called closed formularies, so they may decide that some drugs in a category are covered and some are not covered, but the majority and the majority of our members have an open formulary and drugs are covered. So then the question is, under what circumstances are they covered and how much does it cost? For us at Aetna and for a number of other large national insurers, we do not have any utilization management controls on the antiretroviral drugs. We just place them at the highest copay tier, and anyone can fill a prescription and have it paid for. And then they will have a copay that depends on their plan, which might be $50 or $100, or it might be a percentage, depending on what sort of plan they've purchased. But we don't have a restriction on you have to try something else first. We don't have a need to talk to your doctor about it or any other thing. So what happens is that we really don't know why a member has asked for an antiretroviral drug. So right now we're probably paying for PrEP and we don't know it. We're paying for post-exposure prophylaxis, we don't know that, and we're paying for members who have HIV infection and need to be treated all the time, and we don't know who they are either. Because what happens is at a pharmacy system is that the claims and the claim payment is based on the drug, not on attributes of the member like their diagnosis. So we only know their diagnosis if we put a block in the claim system, and then we require knowing the diagnosis before we remove that block. Generally, that block is called a prior authorization or pre-certification services, and we don't do that for the antiretrovirals because we don't want to put any barriers between someone, getting their prescription and getting it filled and getting on treatment. And we have a number of areas where we don't want to have barriers, so we don't try to control in any way how that prescription is handled. And so you can see one of our problems is our tools are rather blunt, and so we don't want to get in the way of things. You will run into cases, there are all sorts of cases of prior authorization of various services, including pharmaceuticals, and generally that's because there is some need to restrict that particular drug. So we talked earlier today about REMS programs, and there are programs for thalidomide and Accutane, and we have similar programs for some of those drugs and for others because the drug needs to be restricted for one use and not used for another. But we didn't feel that that was appropriate in antiretrovirals, and most of the large insurers will go in that direction. Some will just ask for, does the patient have HIV disease, and they don't go any farther than that, but most have no restrictions on this. So basically, for those who are commercially insured and have a pharmacy plan, then PrEP will be covered along with other uses of antiretrovirals. So that then leads to the question, well, can a managed care company do anything to help with safety concerns or risk mitigation? And the answer here is it's going to be rather difficult because it's all based on the medication, not based on knowing what the member has. For one thing, we don't actually know why a drug is being given. We get an electronic claim from a pharmacy. It comes to us, we're our own pharmacy benefit manager. It may also go to a large PBM like Medco, Caremark, Express Scripts, and in many cases we actually have a lot of diagnostic data about a patient. We have a list of ICD-9s, soon to be ICD-10 codes, and we can match those up to a prescription. The problem is that the diagnosis for which you just got this prescription isn't in the system yet, because the first thing that hit any managed care system is the pharmacy claim, not the medical claim. Medical claims lag behind based on when the hospital, the doctor, the clinic, when they feel like putting it in. But pharmacies put them in right away. They can do it real time, and because this is the only way they're guaranteed to be paid. So they put in their claims right away. So pharmacy claims always show up before new diagnoses. The other problem is that there's no code for PrEP or PEP or anything really. The codes in HIV disease are kind of wanting in terms of explaining what's going on. So we can't really actually make a connection between that pharmacy claim, that prescription, and why the patient is getting it. So if we're going to put REMS programs into place, we have to be very careful not to ask systems to do things they can't do, or else we'll just put artificial barriers up. The other possible way to deal with this is to say, well, we could restrict it to a particular sort of provider. And we don't normally do that at Aetna, but other PBMs do. And you can say, I'm going to restrict the use of this to cardiologists or to infectious disease specialists. The problem in HIV, again, is that there's no definition of an HIV provider that you can find in any provider database that you may have. A lot of ID physicians, for example, are in the database only as internist or pediatrician. We don't know that they're an infectious disease specialist. And we don't expect that we really want to limit PrEP to just HIV physicians who are also ID specialists and are not, it's going to be too limiting. There's going to be plenty of folks who are family practice doctors and others. And so, again, we have to be very careful about using blunt instruments like limiting to a particular specialty, or we're going to really limit too much how the drug is distributed. I'll say a little bit here about limited distribution channels and limited prescribers. We distribute thalidomide and Revlimid and some of the other drugs that are on REMS programs through our specialty pharmacies. And this works out because it's a small number of people. They're being treated for a very discrete set of disorders. There's only 3 things you can use thalidomide and Revlimid for. It's pretty straightforward to deal with that, and almost all the oral oncology drugs go through our specialty pharmacy anyway. And so that works out fine. But when you're going to other pharmacies, we don't want to put another barrier of, oh, you can't go to your local pharmacy to get this medication. You have to go to some special pharmacy and mail it away to this place in Orlando, Florida. That's going to get in the way of patients getting the medication. But because everything's based on the drug and not based on the diagnosis, that means everybody who gets an antiretroviral will have to go and get their drug from the same place. So a limited distribution scheme here isn't going to work because we already have 1.2 million people being treated. So we can't suddenly limit how those people get their medication. There are also modifications to the DEA number. You can have physicians go through training programs and receive a special addition to their DEA number. We do this with Suboxone, for example. There's some other drugs where your prescriber has to have this. This in Suboxone has turned out to be a limiting step in terms of being able to get people access to the drug. It's easier to get OxyContin than it is Suboxone because there's not as many people who can write a prescription for Suboxone as can write a prescription for the narcotics that the Suboxone is supposed to help you get off. So we've run into some difficulties with some of these programs, and we have worked very hard in our behavioral health networks, for example, to encourage doctors and do things to encourage them to go ahead and become Suboxone prescribers. But it's not been easy for us to do that. And the pharmaceutical manufacturer, we've worked very closely with them. So I recommend that the programs that were discussed this morning of incorporating use of PrEP into good practice, into other programs of making community resources available are going to be a much better approach than trying to take a managed care or payment level approach to these sorts of things, because our instruments are just not fine-tuned enough to do a good job and are more likely to get in the way of getting patients on treatment. Aetna's view on this is that this is the right thing to do. The medical evidence supports it. Even if Gilead doesn't get the label, we hope that you do get this as an indication. That makes it a lot easier to deal with. But even if you don't, In addition to covering drugs that have specific indications, we cover drugs for things off-label when there is sufficient evidence. Now, most of the time we don't have a clue why they're being given, so we're not making those determinations, but our policies do allow us to cover for off-label use when there is sufficient evidence, and clearly there's sufficient evidence here. So we're not going to have a problem getting this paid for. We are going to have difficulties if we try to use payment systems in order to control distribution of the drug or try to get people to come and get tested. As a matter of fact, there's going to be a few funny things that will happen in the system. Many large PBMs, Medco amongst them, have programs where the patients who are receiving antiretrovirals are regularly contacted by their pharmacists at their specialty pharmacies or mail service pharmacies to make sure that they're refilling their prescriptions. Patients who go into a PrEP regimen may not refill a prescription at some point because their behavior may change. They and their physician may decide that they should stop using the medication. Now they're going to have to explain that to the pharmacist who just called and said, how come you didn't refill your antiretroviral prescription? So we need to counsel folks that if they're using those systems where they get these sort of reminders, there's going to be some questions about how that's managed. So if I can help anyone with questions around, how commercial payers will process these claims and these coverage decisions and things like that, I know it's a complex issue. That's why I'm around. And so, please feel free to contact me at that, and I'm happy to try to help you out. Thank you.
Okay. I'm Jim Rooney with Gilead Sciences. As many of you know, or most of you know, Gilead is the company that developed, manufactures, and distributes both tenofovir, otherwise known as Viriad, and M-tricytidine tenofovir, otherwise known as Truvada. And these are the two drugs that have been included in the studies that have been described to date of pre-exposure prophylaxis, along with the topical formulation of tenofovir vaginal gel. We have a great deal of admiration for the study teams that have carried out this very difficult to conduct research, oftentimes multinational, oftentimes in resource-limited settings, and oftentimes in stigmatized patient populations, and also to the patients that have participated in the studies to make the data available to help us determine whether this strategy could indeed be a useful tool in the toolbox to help stem the HIV epidemic. In terms of Gilead commitments, I only have one slide, and but it outlines, I think, the four key areas where Gilead is actively engaged in terms of helping to make these drugs available for pre-exposure prophylaxis, assuming that's not currently an approved indication, but obviously one that's supported by the data that's been presented to date. And the areas in which we're actively engaged include supporting ongoing research efforts. That includes both demonstration projects and clinical trials, and includes the provision of drug supply and also grants. For those of you who were at the Prevention Conference in Atlanta earlier this week, two abstracts presented by Ken Mayer's group were looking at characteristics of individuals who might be appropriate candidates for PrEP were presented at that conference. Angela Kashuba's data, she's presented on the pharmacokinetics following administration of a single dose of Truvada, and other studies that will be presented in the near future are studies that were supported by Gilead grants. In addition, Gilead is committed to provide the appropriate regulatory support for filings for PrEP where that is warranted. And we have had discussions with regulators both in the U.S., also in Europe, and some of the individual countries in Europe. And we'll be having discussions as well with regulators in the developing world as the process moves forward. We're also committed to educational efforts for healthcare providers and also for potential recipients of PrEP, and that would include continuing medical education efforts, also web-based initiatives. And in addition, safety monitoring will be an important component of Gilead responsibility, routine pharmacovigilance, as well as was discussed earlier today, the risk evaluation and mitigation strategy plan for the U.S., and there are similar sorts of risk assessment and mitigation strategies that are used in Europe and elsewhere. So those are currently where our efforts are targeted, and I'd obviously be happy to take questions about any of these or other issues during the question session.
Okay, we've run a little bit over, but why don't I see whether there's any questions in the audience? Yes, go ahead.
We have not filed yet, and originally it was a filing that was going to be focusing specifically on men who have sex with men based upon the IPREX data. And as data from additional trials have become available, our discussions with the regulators here and elsewhere have been, what is the package of information that would be most appropriate to submit to the agency for their review and evaluation. So once we have a good handle on the information that's required for submission and the types of things that are involved in the submission, such as the study reports, manuscripts, the data that's provided to the agencies for the regulatory review, once we have a good handle on that, we'll be able to determine exactly what the submission timelines would be. Originally, we had hoped to do it in the first half of this year, but given the data that's emerged from both the TDF2 study and also the FemPrep trial, we're opening those discussions again to try to see what the best package of data for review would be.
I have two questions. One, I think for Aetna, when a drug company comes to you, do they tell you? Do you just tell them whether you'll cover it or not? Do you talk prices with them? Do they say to you, well, this is our range. Does this work for you? I mean, did that sort of conversation happen? And I also would like to ask Dawn, are we going to get a commitment from the CDC that some of these demonstration projects will be in cities other than just San Francisco and Boston?
Yes, we talk to pharmaceutical companies all the time. We have an industry contracting and relations group, and for any medication, a pharmaceutical firm can approach us, and we have ongoing relationships with a number of firms. We negotiate prices with those firms. Now, the way that prices get paid is that the retail pharmacies have a price that we pay them based on our contract with them. And so we don't buy directly from a pharmaceutical firm with very few exceptions. So what happens is the pharmaceutical firm is willing to negotiate a price with us. Then what happens is that we basically get a rebate. So it's like you go to the store and you buy something and the manufacturer says, great, I'm going to give you part of the price back. And that's how it works. And the reason is because we're not buying directly. So we do have contracts for some medications, and we negotiate rebates on those medicines, and then we pass through those rebates either to the plan sponsor. If it's a self-insured plan sponsor, they get their rebates, and if it's somebody who's buying insurance from us, then they get part of the rebate back, and us being able to keep their premium from going up the following year.
In most circumstances, federal funding for anything, for parts for the NASA, for the space shuttle to clinical trials, has to be competitive. And so we will try. Our intent is not to fund sites that already have demonstration projects or open label extensions in place. But I can't promise, because we'll try to limit it in a legally permissible way. But that's something that gets decided as our funding instruments are going through our system.
Well, I wanted to say something about funding of demonstration projects, because this has been a big elephant in the room for me that I don't think it's been addressed yet. And somebody earlier mentioned that we have a lot to learn and could learn a lot from the rollout of birth control pills when they were first developed. And I think we forget what happened in those days. And if you've read anything about it or experienced it, in 1963, when birth control pills were approved and licensed by the FDA, if you were a married couple living in Connecticut and took birth control, you could go to jail. So I don't think societally we're actually where we need to be for this. And I'm very concerned about looking to federal funding. And maybe I'm just overly paranoid, but there are Michelle Bachmans in the world who are going to go absolutely apoplectic over this if you start talking about federal funding for that type of demonstration project. And I want to be very real about what can be done and where we're going to get the money to do it, because there is a huge societal concern, I mean, as a part of this, that there are just not the will or the forces in the right places at this particular time to work in our favor. And I think we really need to be aware of that and address it and be realistic about it.
Let me counter that a little bit. I mean, the federal government spends huge amounts of money on HIV prevention, and this will be one of many activities with the money that they already give us for prevention. Now, that doesn't mean that somebody can't go pouring through our grants and stuff and decide that one or two of them is particularly troublesome to them. But it's not as if we're going to them and saying, let's establish a new program and it's highly visible. I think the main problem that we have at the moment is that CDC, most of the money CDC gets goes out to health departments and to CBOs. We have a very small pot of money for research. And given the pending funding cuts and all of the conversation about this austerity program, we don't know how much money we're going to have to spread around. So I think at this point, our main issue is identifying the funds to do the demonstration projects.
Okay, this is great. We have a lot of questions in the audience, but I think the members of the audience have indicated their willingness to answer questions, and I'd really like to get to our last panel. So if I can ask the next group of panelists to come to the podium. And thank you, Michael, Ed, Jim, Dawn.